what I was going to do today was actually to show you how this global strategy fits in with what is happening in the broader leprosy community. And from the recent International Leprosy Congress in Manila, I've taken some slides from various presentations around these three topics. So you'll see that the global aim, or the aims of global leprosy mission over the next 5 years are towards zero leprosy transmission. You'll note that it says towards, because we don't envisage that within 5 years we will have no transmission of leprosy. We'll talk about that. However, in detailed discussions, we did think it's realistically by 2035, which is only 16 years away, that some of you will be here then, and some of us may not be here then, but that it is realistic to think of interrupting leprosy transmission by then. Then the second aim is towards leprosy, zero leprosy disability, and so I'll talk about some of the issues related to that. And then towards zero leprosy discrimination, which we hope it's not going to take until 2035 to reach, but is something which is achievable within the next 5 years. And that these activities for the leprosy mission, as opposed to some of the other very important and very helpful international organisations, that we are cross-centred, that we are doing this because God, for whatever reason, has drawn us in to the vortex of the leprosy mission, and once you get caught, you can't keep going. It's a good thing, and we'd like to see more people drawn into that vortex. And part of our role is to enable the leprosy mission to have resources and to have the people to do this. So this is a very helpful card, actually. If you turn it over on the back, you'll actually see that there's a circle, and it's not by chance that zero leprosy transmission takes up 50% of the aim, because the other activities will also be greatly influenced by that. Now, if you then look, right, if you've got 3 hands, and look at page 6 of what is the Leprosy Mission Australia, you will actually see that the activities are around zero transmission, zero disability, and zero discrimination, linking to the international agenda. So certainly you may not read every single word of this document, although Sheldon expects you to, and there'll be a test. There'll be a multiple choice question at lunchtime tomorrow, checking that you've actually read page 19 in detail. But page 6 and page 7 I think are very important, actually, and would be the kinds of things that looking at to see how we're going over the next few years. So with that, we'll talk about this, and in fact a number of these slides, and the majority of these slides, are from talks which were plenary sessions at the International Leprosy Congress. And just for this talk this afternoon, I thought I'd give 2 personal reminiscences, one at the start and one at the end, for those who are still here at the end. So Amma, I expect you to be here at the end. So the one at the start, actually, the first International Leprosy Congress I went to was in 1984. So my wife and I were working with Interserve in West Nepal, and then when I came back to Australia, I did a PhD on the immunology of leprosy and became an immunologist, which has been my day job. And the first conference, this conference that I went to, was in Delhi. And I remember very clearly because it was opened by Mrs. Gandhi and by Sister Teresa, and they were both on the stage at the same time, and they were both tough ladies. Sister Teresa was not a pushover. And it was a very interesting conference because it was probably the first conference when the new technologies of immunology and genetics, the very first International Leprosy Conference when immunology and genetics were really being discussed in a serious way applying to leprosy. So since then we've learned a lot about leprosy. But I probably thought that 35 years later I would still not be going to international leprosy congresses. And I've been to them each one. And they used to be every 5 years. And then in 2013 it was in Brussels. And by this stage, the leprosy elimination agenda had been going actually for 22 years. And they booked a small venue in the centre of town thinking not many people would turn up. And the conference was oversubscribed. They had more than 800 people, they couldn't fit everybody in. And the reason was leprosy hadn't gone away. And as I'll show you in one slide, this was when really people seriously thought that just doing the same thing over and over again will not actually get rid of leprosy. And then there was one 3 years ago in 2016, and then another one now in 2019. And the fact that they're occurring more frequently is about the issue of generating international recognition and support for the serious issue of how are we going to get rid of leprosy. So that's the background. In 3 years' time, there's going to be another conference actually in India. So who knows? So this slide I showed you 3 years ago, or 2 years ago, because this is still the current WHO 2016 to 2020 strategy. Now you may say, why is this important? What the WHO strategy is determines what national country strategies are. So the Leprosy Mission might have a strategy, and the Global Alliance for Zero Leprosy may have a strategy. But if you're a health minister, right, with lots of health problems, it's what the WHO strategy says is what determines your agenda. And which we heard about Timor-Leste earlier, because Timor-Leste had reached the magic number of less than 1 per 10,000, therefore you can eliminate leprosy control, even though leprosy is not eliminated. But this actually set targets around transmission, and I'll show you in a moment that children are a very important measure of transmission of leprosy. Targets around disability, those who had visible deformity, and targets around legislation about leprosy, eliminating those. It's not setting targets around numbers of cases found, but measures of transmission, and childhood leprosy means that leprosy is being transmitted in the last 5 to 10 years, disability of leprosy, and discrimination against leprosy. And every year in September, in the WHO Weekly Epidemiological Report, there is the report of the number of new leprosy cases detected in 2018, and you can actually see that the distribution is similar, where South Asia has a major component of leprosy. Indonesia, in particular, is increasingly recognised, and Brazil. And then there are significant numbers of patients in different African countries, but they're all smaller numbers. And I realise that you can't see these numbers, so I put it down the bottom here. In 2018, there were 208,619, so about 210,000. And you can actually see there has been a decline over the last 10 years from 244, but in fact there's been no real significant change for the last 5 years. So what that indicates is the level of transmission of leprosy in these communities is continuing. and the number of new cases is continuing at about the same level. And this is just showing the same thing, that over the last 4 or 5 years there's been this plateauing. And in blue we have the number of cases in South Asia. This is the number of new cases detected amongst children. And again, at the top we have South Asia, which is India, Nepal, Bangladesh, Myanmar. And you can see there is still a rate, a greater than 1 per, I think it's 1 per 100,000 of children under the age of 14 with leprosy. In Papua New Guinea at the moment, and this is evident in the numbers, a copy of which I've got if you would like to look at them, 25% of leprosy cases in Papua New Guinea are in children under the age of 14, which tells you that there's a lot of transmission of leprosy at the moment in Papua New Guinea. Now, this is from Can Smith, from a review he did some years ago. You'll remember, or for those of you who've been involved back here, you'll notice 1985, the year after the first leprosy conference I went to. You can show this slide in different ways. You can show this slide and say, leprosy elimination has been a great success. It was estimated in 1982 or something, there were 15 million cases of leprosy in the world, and millions of cases have been treated. We've done infinitely better in the control of leprosy than we've done in the control of TB. Right? In fact, there are more cases with TB now than there were in the 1980s. Right? So leprosy control, and it was this 9-year period which was then extended out to 2005, which is the period of time when Mr. Sasakawa from Japan invested $400 million with WHO, US dollars, not Australian dollars, and which led to a major investment in leprosy control. And you can actually see in the late 90s, there was this intense period to try and find every leprosy case by the year 2000. Unfortunately, the leprosy elimination program, although it treated millions of patients and actually in public health terms was a great success, it didn't eliminate leprosy, right? It reduced leprosy in prevalence, but it eliminated many leprosy control programs around the world. It eliminated research in leprosy, it eliminated public interest in leprosy. And to many health ministers, it had eliminated leprosy. So there was this rapid decline in the number of cases, and that was mainly due to reduction in case detection. The incubation period of a disease influences the rate of appearance of a disease. So that's why we see patients in Sydney, and I'm sure Murray used to see patients in Melbourne as well, who came to Australia as immigrants from Nepal, from Bangladesh, from Indonesia, from the Philippines. They were perfectly well, perfectly fit, right? And 5 to 10 years later, they slowly developed signs of leprosy. That's because the leprosy bacillus was living in the body. And the reason the incubation period is so long is the organism takes incredibly long to replicate. It takes 14 days to multiply. So this actually means that leprosy will continue to appear, and you need to have an approach to how you're going to get on top of that. So these undiagnosed leprosy patients represent the missing millions, and they transmit the leprosy. So once a person has active leprosy and the organism's in their nose, they can cough or sneeze and transmit to other people. And if it takes a year to diagnose them, that's a year in which they can transmit it to other people. Okay, that's the principle. So there are two ways to find leprosy. One is to wait until the patient gets sick, and goes to someone who recognises they have leprosy. That's actually how most diseases are diagnosed in the world, right? You wait until the person. And that actually means you need to have an awareness so that the health services and the patient know that leprosy is a risk. The second way is to look in high-risk groups to see if you can find cases with leprosy. And the high-risk group, which has become a focus of attention over the last 4 to 5 years, are the contacts of leprosy patients. Now, if we had a test which would detect whether a person had early leprosy infection, we could then say, well, we will treat this person. We have such a test for detecting if a person has tuberculosis infection. And we now have a blood test as well as skin tests. And so if you find a person who's got tuberculosis infection, you can discuss with them whether you want to treat them and what is the risk of them getting the disease. It's about 7% in their life. Right. In leprosy, we don't have any such test. The second thing, though, you need a preventive therapy which will work and prevent the development of disease. Okay, so that's the background. And I thought I would just present some, developments over the last 3 years. There is this new organisation called the Global Partnership for Zero Leprosy. And this really emerged at the last International Leprosy Congress that was actually in Beijing. And the development of that came from the Brussels meeting that I mentioned. And it was the recognition that there was not enough support, there was not enough financial support going into the control of leprosy. And this is a global partnership which includes ILEP, WHO, Novartis, and all of the major leprosy organisations, including ALM and TLM International, the Dutch Leprosy. And if you go to this website, which I suggest you do, the one thing about North American organisations, they almost always have good websites. And this is an extremely informative website. And it's interesting, it's based in Atlanta. In one of the universities there, and it's particularly there to promote increased resources and research to reach the targets for global leprosy elimination. And Bill Simmons, who's the CEO for the American Leprosy Mission, is the chair of that. And there is increased focus, that I'll show on the next slide, for what are their important aims. So one of the components of the zero leprosy agenda is around zero discrimination. And I spoke about this at length 2 years ago, so I knew Armand was here, so I won't talk about that as much. But there have been a couple of major developments over the last 3 years. One is the appointment of a special rapporteur from the United Nations for leprosy. And the person who's been appointed to this role is a Portuguese social scientist, Dr. Alice Cruz. Special rapporteurs are people who have access to governments which are part of the UN system. So there's a special rapporteur for many, many different conditions, TB, HIV, other kinds of conditions. And when they visit a country, they can always go and meet the health minister. And so it was the Sasakara Foundation which pushed for years and years that there should be a UN special rapporteur for leprosy. And it's within the context of disability and encouraging countries which have signed up for the UN Charter for Control of Disabilities to actively include leprosy. And in particular, her approach has been what's called a human rights approach to leprosy discrimination. And if anyone's interested in that, her plenary session at the conference is available, and I could give you a copy of those slides because they were made available to us. The Leprosy Mission has really become actively involved in this area, and Pradeep Bhagwal has been appointed as the anti-discrimination advocate. And he's worked particularly with AMA and IDEA, and Brent, the International Director for the Leprosy Mission, and AMA have gone to the United Nations and attended meetings of the Discrimination Committee. I think that was right. Is that right? I've got that. And AMA could tell you about, I'm not quite sure because I had to step out whether you talked about that. But this is a new area encouraged by the board of the Leprosy Mission and the members for the Leprosy Mission to be actively involved in this discussion. And Pradeep is particularly able in this area because he's worked for the United Nations in all kinds of places, in North Korea, Cambodia, Afghanistan, and he's based in Delhi. He knows how Indian governments work, and he's actively involved in lobbying for the removal of laws against leprosy patients. And I think there's there were 144 laws. We're down to 140. What's the number now, Arma?
Yeah, 140.
Yeah. And so this is, and before this conference, there was a special meeting of people affected with leprosy before the meeting, and members of the Leprosy Mission are actively involved in this movement. So I won't talk more about that today, but that's actually, in a sense, I'm not quite sure to the extent we tell our supporters about this active involvement of the Leprosy Mission in this international, and I'm sure many would be interested. Okay, the second international organisation now is the Leprosy Research Initiative, and this was established in 2013 in Brussels, and there are a number of partners, each of whom agreed to put in, I think, 100,000 euros to form a kitty, which is then supplemented by a Dutch philanthropist who was the person who developed GPS navigation systems in Europe. And this person's actually given millions of euros, mainly through Dutch organisations, for leprosy research. The Turing Foundation is called, Turing. And the original members of this were the Netherlands Leprosy Relief Association, who've changed their name, I see, to No Leprosy Remains. What was the Canadian Leprosy Mission, the ALM, the German Leprosy, TLMI, and the Damien Foundation. And each put in 100,000 euros, and they get about $1 million. So that's not too bad, that's a 2-to-1 support. And that has been then used as a kitty to support leprosy research. And there's a number of associate partners. And there was a very good presentation from the technical officer for this, Dr. Veldhuizen. And you can see it was launched in 2016. The first proposals were supported in 2015. This is a large European funding group which contributed significant amounts of money, especially to studying post-exposure prophylaxis. And the annual research budget is 1.3 million euros. And the way this works is people put in a letter of interest if they're then asked to put in a full proposal, and you can actually see that about 16%, which is twice the rate of funding from the National Health and Medical Research Council in Australia, which I can assure you is one of the toughest places to get funding in the world. But you can see there have been 43 research projects. We've worked out that the Leprosy Mission, for its 100,000 euros, gets about 3 times as much back in research done in its centres. And not only does it fund research, but it also is particularly about strengthening research capacity in endemic countries, to which the Leprosy Mission has been committed very strongly. And it has these workshops on operational research, one of which was held at an Underbun Leprosy Hospital, and here's an example of that. And one of the things that they want to do is actually take research findings, and this is her slide, and implement these research findings so that they actually influence policymakers, so that they actually lead to the control of the disease. So it's one thing to do research and say, right, this is how we should treat this condition, but to make sure that it's being implemented and that national governments are listening. So this is probably a perspective that many of the supporters of the Leprosy Mission don't have, but in fact, it's actually what people in the Leprosy Mission International are actively engaged in, trying to influence governments in a positive way. Now, so these are these 2 organisations. This symbol here is the Leprosy Research Initiative and the Global Partnership for Zero Leprosy. And they have set priority areas for research about diagnostics to detect leprosy infection, to block transmission, to prevent disability, to eliminate stigma, and to provide training in the skills and the technical capacity to eradicate leprosy. Now, we discussed this. The Leprosy Mission has a research committee, which I've chaired for a number of years, which also functions as the research working group for the Leprosy Mission. When we discussed this in a meeting the day before the Manila meeting, we added that one of the focuses of the Leprosy Mission is also around patient-centred care. It's not only about elimination of the disease, it's also about care for individual patients. So this has actually been quite a success. And one of the senior staff in the Leprosy Mission office in London, Janine, is actually on the allocation committee. You have to make sure you have someone on the committee not to necessarily influence the decisions. It's in fact actually a very rigorous committee, but so that we understand the processes and can participate in this. So it's become an important funder of leprosy research, and it's particularly around strengthening research capacity, which we've been doing really for the last 20 years. And it's using the results of research to impact on policy and practice. And it's a very important thing to do. And it is now collaborating with this American-led organisation, which is a global partnership, which is really the major sources of funds are still in the United States, and that's what they're trying to access. Okay, so are there any questions about that? I'll then talk about zero transmission and zero disability. So what do we mean by zero transmission? Zero transmission, it's actually helpful to set as a goal, and we've actually set it as a goal for 2035, right? But it's a very hard thing to measure. What we really want is zero leprosy cases. As I told you, if we stop transmission, because leprosy has an incubation period of, how long? 10 to 15 years. It would take 10 to 15 years to stop, not to ever have another case. And in most parts of the world where leprosy has disappeared, whether it was Norway or whether it was Australia, leprosy was endemic in the northern territory. It's normally taken at least a generation, sometimes 2 generations. That's the kind of timescale. Leprosy has been all but eliminated in the district where an Underbund hospital is. An Underbund hospital started work in 1959, right? So that's actually what's happened historically. How do we make that happen more quickly? An interim goal is to reduce the number of new leprosy cases to a level so that there is no evident transmission. Right, that's what happens in Australia. Australia's got leprosy eliminated. We still see a small number of leprosy cases, but they don't transmit it to anyone because they get treated. Okay? And so because of this prolonged incubation period, there will be continued need for new cases to be treated even when we block transmission. What happens, and this has happened historically over the last 50 years, as leprosy becomes less common, the patients get older, they're more advanced, and they actually have increased disability. The reason is it takes longer for them to be diagnosed. So you get your leprosy diagnosed in Delhi much more quickly than Sydney, unless you happen to go to a dermatologist from South India. So one of the hospitals in India has in Sydney, Liverpool Hospital has a dermatologist, very good dermatologist from South India who can recognise leprosy very quickly. But that's not common. Okay. And therefore, you need to have some mechanism for providing for those. Now, the major role is still early detection and treatment. And that has been the strategy since 1991, and it remains the strategy. However, we have reached this plateau, and the question is, how do we make the plateau fall? And so there have been a couple of measures. Firstly, the targets have to be realistic. And it's not that important what are the number of leprosy cases in a whole country like India. It's the number of leprosy cases in the northern part of India where leprosy is transmitted. In Nepal, most of the leprosy now is in the Terai, right? And so you have to have leprosy services in the Terai, and that's why an Underbund Leprosy Hospital has clinics in the Terai, but also another Christian-run hospital is based in the Terai to look after those patients. And the thing which tells you that leprosy is still being transmitted in a community is the number of child leprosy cases. It's a surrogate measure and a very important measure. Yep. Now, how have we been going with this? Well, at the conference, Dr. Peter Steinman, who's from Switzerland, from Basel, presented findings of, he presented the results of leprosy post-exposure prophylaxis over the last 3 years. So I talked to you about this a couple of years ago, and you will have read about this. The post-exposure prophylaxis is being used in the contacts of leprosy patients. And the idea is all of the people who are contacts of leprosy patients, but who don't have leprosy, are at risk of getting leprosy in the future. Might be 15 years, might be 20 years. So a way to prevent that is to give them a short course. And a single dose of rifampicin in Bangladesh was shown to be effective to an extent. So the idea is that you give the contacts of leprosy patients without the sign of leprosy disease a single dose. This actually means you have to have technically competent staff who know what leprosy looks like. You need to have an environment in which you can confidentially examine patients, especially girls and women patients, right? And then you have to have the availability of the medicine. Now what is the evidence for this? The evidence for this actually comes from the Leprosy Mission Centre in Bangladesh. almost never mentioned that it comes from the Leprosy Mission Centre in Bangladesh. But Jan Hendrik Ricardus was a missionary in Thailand and then a missionary in Bangladesh. And when he went home to the Netherlands, he continued extremely important research studies in Bangladesh. And what this showed, if you were a household contact, you had, compared to the background rate in the community, you had about a 14-fold increase risk. If you're a blood relative, your risk is higher, and we know that there is a genetic influence on the risk of development of leprosy. And if the patient, the index patient, is multibacillary, the risk is higher. So they did a study which was in Dilfamari in Bangladesh over 8 years, in which they did a randomised control trial of 20,000 contacts of 1,000 leprosy patients. And they've now followed them up for 6 years. And they actually showed about a 50% reduction after a single dose of rifampicin. We know that BCG, which is the vaccine given to children, has about a 50% protective effect against TB. And all of the countries in Asia which have seen a marked reduction in leprosy have had effective BCG immunisation programs. And countries like Papua New Guinea, where the BCG immunisation program has all collapsed, that's one of the factors. And in this population, if you'd had a BCG as a child and were given single dose rifampicin, your protection was even higher. Now, this was the basis for funding from the European Clinical Trials Group for studies in 8 countries. And I've just highlighted in red the 2 numbers. But so this was in Brazil, India, Indonesia, Myanmar, Nepal, Sri Lanka, Tanzania. They had 9,500 registered patients with leprosy and about 9,186 participated. And of these, there are 179,000 contacts. Right? This is big. These are big numbers. And they screened 174, you always lose some, and 23,000 didn't want to participate. But amazingly, 150,000 did. And there's a lot of discussion about this. You'll remember, Sheldon, in 3 or 4 years ago as to whether leprosy patients would be concerned about confidentiality. But it turned out that most people knew they had leprosy anyway. And when offered a protective measure for their children, it's not a complete protective measure, as you said, but it has definite. So there were some refusals. But you'll notice, and you'll see on the next slide, when they looked at these contacts, they actually found over 800 leprosy patients. So 86% of the contacts agreed to be treated. And 810 new leprosy patients were detected. And if you do the numbers, that works out at about 0.6 to 0.7% of contacts of leprosy patients had leprosy. Now, it has been said in the notes, I've lost somewhere in WHO, that it was recommended that contact screening be done, which of course is what happens in Australia. If there's a TB case, a leprosy case, the relatives, household contacts are screened. But this was not being done essentially anywhere in the world. But it has now been done in 150,000 people and 810 leprosy patients found. So this has actually been implemented with external funding now on a large scale. And it's been demonstrated that this is feasible across different health systems in 8 different countries in the world, with generally good participation and acceptance. It really is important that this is done through a local effective primary healthcare system. And so we were talking earlier that, in fact, one of the criterion for leprosy control is actually to have a good primary healthcare system. It works better for contacts in the household, but one of the effects of this, and I know this is the case in Nepal, and Armam I'd like to comment as well, that this has kind of reinvigorated the leprosy control program. They actually said, well, we've got something to do. They've gone and examined people and they found new leprosy patients. And when one child's been found to have leprosy, the parents are quite happy to agree to have the other children treated. And there have now been extensive analysis of what is needed to integrate and expand this. I think in the longer term, it would be better if they're using 2 drugs. If you use 2 drugs, of course, it doubles the cost for the drugs. But in practice, actually, most of the cost is not the cost of the drugs. Most of the cost is actually delivering the program. So this is something which has happened in the last 3 years with external funding, and now the argument is to make the argument for countries such as India, Indonesia and Brazil to implement this. And I know Brazil is looking at it. At the end of last year, in December, an expert committee for WHO brought out a new set of guidelines for the diagnosis, treatment and prevention of leprosy. Again, without going into this, there are quite strict criteria. Once upon a time, this used to be a group of experts got in a room and wrote what they thought. Now there are quite strict criteria around drawing up these guidelines. And for the first time, the guidelines recommend the use of single-dose rifampicin for preventive treatment for adult and child contacts of leprosy patients after excluding leprosy and TB. So this is actually a very significant development in the field. There was a question about vaccine. As I said earlier, BCG should not be ignored as a vaccine. In fact, it's more protective against leprosy than it is against TB. But in 2003, the American Leprosy Mission, through contacts which I could discuss over dinner, got in contact with this guy, Steve Reed, who's a very brilliant American scientist, but quite entrepreneurial American scientist, who decided in 2003 to try and use the accumulated information to make a leprosy vaccine. Part of the issue about this is you need to have what is called an adjuvant, which is part of the vaccine. And none of the major companies would take this on because there's not a big enough market for it. And so he persuaded the American Leprosy Mission to fund this, which they've done to well over, I think, $1 million over the years. And for about 10 years, myself and 2 American scientists, Tom Gillis and Pat Brennan, were a little kind of committee. We used to meet every couple of years and talk to Steve Reed, and he totally ignored what we advised him to do. If you become a successful American entrepreneurial scientist. Anyway, he used to put up with us a bit, and we'd write a report for Paul Sanderson, and the American Leprosy Missions kept funding it. Anyway, they have a facility in Seattle where they can make the vaccine for human use. They've tested it extensively in mice and armadillos, and if you're interested in the armadillos, I could tell you about that later. And at the end of last year, or in October last year, they did a phase 1 safety study in humans. And this consists of 4 proteins from Mycobacterium leprae, and this is to show that this vaccine that they called Lepvax had a protective effect in the mouse foot pad model. There were other vaccines beforehand which had just as a protective effect as this vaccine. The issue is that they have they're basically a biotech company and have the capacity to produce this as a product. So when I visited there last July, they had a kind of Lepvax in a vial, actually in a Perspex box, I think to show the American Leprosy Mission that yes, we produced this. And they have actually done a study, and this is all unpublished information, where they've shown that they have induced an immune response in 11 volunteers. An effective prophylaxis. No infectious disease has ever been eradicated without an effective vaccine. That's actually the history of it. So we will, these things will develop. But I think both Steve Reed gave an excellent presentation, as did Peter Steinman. So zero disability is zero, the actual target is zero disability in newly diagnosed leprosy patients. It's not disability that develops during or after treatment. And it's not disability that's already occurred in patients with leprosy. Okay. In fact, though, what is often ignored, but is extremely important in leprosy mission circumstances, is this is from the time that a person with multibacillary leprosy is initiated on treatment, the proportion of patients who do not have reaction. So you can see, and this goes out 2 years, 3 years, 4 years, 6 years. Only 30% of patients never have a reaction. But a lot of them occur after the start of treatment. And this is a typical type 1 reaction, and which is one of the major causes of nerve impairment. Now, Diana, and this is the results of this in this Nepali teacher who has had bilateral ulnar and median nerve palsies in both hands. Now, Diana Lockwood, who has been the doctor in charge of leprosy control in the United Kingdom. The United Kingdom was big enough and had enough immigrants that they have had a special unit for managing leprosy in London. And Diana has led that for the last 15 years. And she's been responsible for a number of clinical trials to improve the outcome. Now, the only reason I show this is in red on the left-hand side. These are the different clinical trials since 2003 to 2017. The ones in red all occurred in leprosy mission centres. They were generally funded by external bodies, and certainly this and the others were actually designed by Diana and other people who didn't work for the leprosy mission. Okay, these have been very important trials to try and improve the management of type 1 reactions. They could not have occurred if there weren't centres like the leprosy mission centres that provide high quality care for patients. Because if you provide high quality care, the patients come back. And you can't do a clinical trial with an outcome of 1 or 2 years unless the patients are going to come back. So this is a hidden commitment. Now, Diana is absolutely upfront and thankful. Diana has been on our Leprosy Research Committee for 10 years. She's not a member of the Leprosy Mission, or wouldn't be a member of the Leprosy Mission, but she's incredibly supportive. I guess the point I'm trying to make is the Leprosy Mission is part of a larger partnership at many different levels, from advocacy at the United Nations to running clinical trials in its centres to running large-scale clinical trials in Bangladesh. They're not always badged the Leprosy Mission. To me, that doesn't matter.
as long as the contribution of the Leprosy Mission is recognised and everything is done in a way which protects the interests of the patients, which is actually done. Now, to move on for this, one of the second kind of leprosy reaction is called ENL, or type 2 leprosy reaction, and the treatments for this are not ideal. And over the last 7 years, there's this international collaboration that includes the Leprosy Mission Trust and its hospitals in India, and Anandaband in Nepal, and a number of others. And they have conducted a whole series of studies to improve the care of leprosy. And Dr. Joydeep Darling, who is the research person for the Leprosy Mission in India, actually was a plenary speaker at this conference. It's a long time since there's been a Leprosy Mission plenary speaker at these international conferences, actually about ENL, and presenting the findings of these studies. And I won't go into them in detail, but one of the important things is that ENL, and I think Amar was attesting to this today, is a major cause of morbidity and mortality. It's one of the ways you can die from leprosy. It is actually very demanding on services. It causes economic hardship. Most people with ENL end up poor, and it has major social and psychological impact. And to attest to this, we, without breaking confidences, we have a patient in Prince Alfred Hospital at the moment from a leprosy endemic country with ENL that requires all the services of a modern quaternary hospital for management of this lady. And yet these patients are being managed in clinics all around the world. How to do that? This is just to show from Anandaband that the length of the first episode is 18 months, and this is 6 years. That ENL can continue for up to 6 years, which I think is what actually Amar told us earlier today. So ENL is a very significant problem. The best treatment for ENL is thalidomide, and thalidomide is used in men but is not used in women because of the teratogenicity, unless they are older. And it also has other complications. It's also expensive, but many countries in the world don't allow you to report it. So it is actually an issue that we have a drug which can work, but many countries will not import it because one case of thalidomide embryopathy is a disaster for a health system. So this Enlist collaboration is doing a randomised clinical trial of a drug called methotrexate that's used to treat rheumatoid arthritis. That is actually funded for 900,000 euros from the LRI. And Leprosy Mission hospitals are some of the major contributors to that. In fact, at Anandaband, they are doing a trial of a drug developed by an American company called Celgene, which is a major American up-and-coming pharmaceutical company that has developed a novel anti-inflammatory drug. And Anandaband Hospital, for those who've been there at Anandaband, it's kind of basic hospital. It is doing this clinical trial of a first-in-human. It's not the first-in-human, it's been given to humans for other inflammatory conditions, but the first for leprosy. And this has been done in a very serious way. There's a data management and safety board that I chair, and every 3 months we have a telephone hook-up between New Jersey and Norway, England and Australia. And this is an example, and this is just to show with this drug that you get reductions in the inflammation And this is just to show Dr. Mahesh Shah, who's the senior dermatologist at Nandabang, presented this. And that's the reason I'm showing you. He presented this at the International Leprosy Congress. And if this pans out, we will do a major study. Finally, one of the really big problems in leprosy is foot ulcers. It's not something which always draws attention, but the treatment that we use for foot ulcers is very pragmatic. There's actually not a standardised treatment. Leprosy, and I think Tim actually asked me about this earlier, leprosy is now included as one of the neglected tropical diseases. And another neglected tropical disease is Buruli ulcer. And about 12 months ago, the Leprosy Mission in England and Wales had discussions with the University of Warwick in the UK about applying to a European, an English funding body called the National Institute of Health Research, which is the major funding body for determining whether the NHS will take up new treatments. And they give it, you know, this is funded to £1 billion or something, and they give a small amount for global healthcare, might be 2 or 3% of their budget. Anyway, they applied for a project for the management of leprosy, foot ulcers and Buruli ulcer. This is called the RIGHT project, and it contains about 8 of the major kind of implementation research, cost effectiveness research, the Wales Wound Care Centre, all of these groups throughout Britain. But where are they doing the work? In India, Nepal and Nigeria. And this is funded to the tune of over £3 million to actually do a number of things, but one of them is a randomised clinical trial of a treatment using biological dressings. Because it's something I thought I could tell you about, because I won't offend you too much. But probably when I tell the members at the board meeting in a couple of weeks' time. So, you know, research and innovation is actually important. But the LRI and other research projects funded by the NIH, Deanna's had NIH grants, the National Institutes of Health Research, they depend on TLM centres in Bangladesh, India, Nepal. And these require core funding from TLM members. But there has actually been a reluctance of supporting members to fund research components of implementing country budgets. Now, I've never understood this. I guess I've always had a conflict of interest because I chair the research committee. But I guess I'm on the board now, so I can say what I think. And they can only kick me off. But it's interesting. And why is this the case? It is increasingly recognised in high quality health services in Western countries, like the one where I work or where Murray worked at the Royal Melbourne, that research is essential to provide evidence base for providing the best healthcare and also providing the most cost effective healthcare. And if we're ever going to reach the zero leprosy agenda of the Leprosy Mission, we're not going to actually do it with the funds that we get from the Leprosy Mission, actually. We're going to have to do it with research findings, evidence findings, supported by these other organisations, who actually depend often on us to be able to do the research. But it does require us to provide committed research funding. And there's been a particular problem in the last 12 months to fund Bangladesh. And again, I don't know to the extent that we talk about these things out of school, but you know, when one of the former funders of Bangladesh pulled out, right, which was not the Leprosy Mission, but our leprosy implementing countries often get funds from other organisations for part of their project. One of those funders pulled out, and 20% of the budget for the leprosy mission in Bangladesh disappeared overnight. So the poor director for the leprosy mission in Bangladesh, what do? Do you sack half your staff? Well, not half your staff, 20% of your staff. How does the research program weigh up against other essential components of the program? You've got to do things to maintain faith with the National Leprosy Control Program. So I guess the thing I've learned from being on the board, and I think Jenny and Colin would say the same, is that, you know, hard decisions have to be made about what is cut and not cut in an environment much, much tougher. Now, working in a big hospital, I work at RPA in Sydney, we're used to budget cuts and fighting our case and going and banging on the door of the chief executive. Or you don't do it very often, but every now and then you do. It's absolutely nothing compared to the problems of the continued funding for leprosy mission projects. So the research sometimes is seen to be academic or not the immediate agenda. But I guess what I've tried to show you today is that in many cases, research done in leprosy mission centres is fundamental to our understanding of, and will continue to be fundamental. Right. So how do you do it? In the hospital environment, it often occurs through rebadging research. And for many years, many of us used to hide the research we did so that the chief executive didn't quite know about it. And, you know, kind of researchers are always good at that. But in fact, research is innovation. Not all innovation is research. But research is essential for innovation. I've wondered if we should rebadge the research committee for the leprosy mission, the innovation committee for the leprosy mission. Personally, I think TLM undersells itself as a research organisation. So I can say this to you, because you're my friends. But I think, you know, some member bodies, they think that's not the right thing. Whereas the American leprosy mission unequivocally says this is its function. Its function is not to care for all leprosy patients, but to actually do things which help leprosy in the longer term. And that's why it's a very good thing that Bill Simmons, who's the chief executive of the American Leprosy Mission, is the head of this global partnership. I think that's a very positive thing. So I think we should be presenting the Leprosy Mission as an innovation, evidence-led organisation more often. And I actually think that appeals to a younger audience, actually. Okay, if there are any suggestions about how I should present this in 10 days' time, to tell people they shouldn't be scared of supporting, and someone somewhere should be putting their hand in their pocket to support the leprosy research program in Bangladesh. Often the country leaders, and again I can say this, I think, often the country leaders find it hard to present that. You know, they don't necessarily have the longer view. They can't see what's happened over the last 20 years in a place. And we're in an organisation, I was thinking about it when we had the excellent discussion about giving earlier today. The Leprosy Mission is now organised as a relationship organisation. It's a relationship between supporting countries and implementing countries. It's very relational. The American Leprosy Mission is not relational. The global partnership is not relational. It sets priorities. And the LRI sets priorities. The LRI doesn't have foot ulcers on its priorities. Yet 70% of the beds in any leprosy hospital at any one time are occupied by people with foot ulcers. So So I'm just saying, as an if we are going to be taking this kind of thing seriously, I think the Australian Leprosy Mission should be, I guess, in the vanguard of showing both to the wider fellowship, but also to our own community, that we're a changing, living, vibrant organisation, interested in innovation, interested in doing evidence-based healthcare, and evidence-based discrimination removal, evidence-based disability prevention. Okay, right.